When patients receive CAR T-cell therapy, an autologous CAR T-cell therapy where we take the patient's T-cells and manufacture them into CAR T-cells, it takes about 3 weeks or so to manufacture these cells. And during that 3-week period, patients who have very aggressive disease, aggressive lymphomas or aggressive cancers, their disease may get worse during that period of time. And so people have wondered, what if we gave them some either chemotherapy or radiation or another type of therapy to try and do what's called give them bridging therapy so that they can keep their clinical state that's well, keep their performance status good, and keep their disease under control during that 3 weeks that they're waiting for their cells. And so no one really knows what the optimal type of bridging therapy would be. So what I presented was based on an analysis from a 17-center US consortium of patients who are treated with standard of care Axicabtagene, which is a CD19 CAR T-cell therapy for aggressive lymphoma. And what our results showed was that patients where the physician chose that they should receive bridging therapy actually were much higher risk patients than the ones who had chosen not to receive bridging therapy. They more often had a poor performance status, they had higher levels of something called LDH, and in general they had more high-risk features than patients who were not chosen for bridging. So perhaps unsurprisingly, patients who were chosen for bridging did not have as good outcomes after CAR T-cell therapy. They had poor progression-free survival and poor overall survival. However, because these baseline differences were quite different, we tried to match the patients based on their propensity for receiving bridging therapy in order to do some statistical kind of matching to try and see, is it the bridging or is it the patients themselves, that the biology of their disease themselves that is leading to this poorer outcome. And by a technique called multivariable analysis and another one called propensity score matching, we were able to determine that although the effect of bridging did not seem to affect progression-free survival, we still found that patients who had bridging had a poorer overall survival. So it's possible that there's something about bridging that is affecting CAR T-cell outcomes. However, it may be that these statistical tests just don't match perfectly what's really going on with the patient when a doctor chooses for them bridging therapy. So at least we can say bridging therapy is probably not good for the patient, and not every patient should receive bridging therapy. And I think more work needs to be done in order to determine exactly if there are any types of bridging therapy that might be good for patients who are getting CAR T-cell therapy.